what I'm asked to do is to talk about acute stent thrombosis. So we know that stent thrombosis is a rare but kind of devastating condition where the mortality reaches up to 40%. MI is much higher. There are a lot of timings in stent thrombosis. We know that acute stent thrombosis is anything happening within 24 hours, and it also includes intra-procedural stent thrombosis. But we know there is subacute, early, late, very late. And as I already discussed, intraprocedural stent thrombosis is one type of acute stent thrombosis. And both bare metal stent and DS can have this kind of complication. We also know the ARC criteria of the stent thrombosis could be definite, probable, and possible. So I will not go into details of any of them. Just to give you a perspective, these are a few major trials that have looked at different types of thrombosis. And you can see that acute stent thrombosis rate in Horizon AMI was 0.9%. In Acute trial, it was 0.3, and so on and so forth. So average, it is, if good work is done, it should be less than 1%. Now, coming to acute stent thrombosis, it is a rare but a devastating condition. Of course, when it happens, patient presents with massive chest pain, shortness of breath, loss of consciousness, and it remains a challenging task still, despite application of modern techniques and even newer dual antiplatelet therapy. So what I will try to do today is talk about prevalence, the risk factors, the prognosis, and then multiple potential mechanisms of it happening, address some of the knowledge gaps, discuss about the diagnosis, and finally, regarding management of patients with acute stent thrombosis. So a little bit about history. Some of you who are old enough might remember that in the BMS era, stent thrombosis was actually quite high. It was 30%. But over a course of time, the rates have now decreased, in between decreased to less than 1.7%. And the reason was the use of adequately sized balloons and high pressure post-stent balloon dilatation. So these were two things. The balloon before the stenting and after was the one which actually reduced this risk, and also appearance of dual antiplatelet therapy with coming in of clopidogrel. So after these two things happened, the acute stent thrombosis rate decreased dramatically. The Dutch stent thrombosis registry showed that with bare metal stent also, the acute thrombosis rate was 0.6%. Later on, multiple registries showed that DES also achieved same kinds of rates. So this was like before the third generation or fourth generation DES. But after the latest generation of DES have become available, you can now see that the rates are less than 1% with newer generation DES, and even superior to bare metal stent. So nowadays we can say that with modern stents, the acute stent thrombosis rate is lower with DES rather than BMS. And you might remember that people used to discuss in bleeding patients what kind of stent to use, whether to use BMS or DES. Now it is very clear that DES is the one which will have, the newer generation DES is the one which will have even a better efficacy compared to BMS in terms of stent thrombosis. Now coming to prevalence, as I said, the usual rate is 0.1 to 1.7%, but with modern techniques and model therapy, it should be less than 1%. However, if it happens, then it is a catastrophic event. About 80% may develop acute myocardial infarction with more than 45% mortality. So, but as I already discussed with newer therapeutic strategies, particularly pre and post balloon dilatation, better understanding of pathophysiology, identification of patients who are high risk. I think that is a critically important thing because the condition is so rare that you don't need to bother about every patient, but you really need to know which are the patients who are at higher risk of developing acute stent thrombosis. And so that identification part is important. Once you do that, then the risk can be pretty low. The Euromax trial showed that if the acute stent thrombosis has to happen, it happens during the procedure or within about 2 hours. So this is the most common window. After that, risk of developing acute thrombosis goes down because by that time, whatever anticoagulants you have given effects will wear off. And so if acute stent thrombosis has to happen, it will happen about 2-hour interval. Now, looking at the risk factors can be patient-related, procedure-related, or post-procedural factors. But at this stage also, I would like to say that the most important factors are the procedure-related factors. So for acute stent thrombosis, it is generally inadequate procedure done. For other things, it could be many things. It could be dual antiplatelet therapy, inadequate dual antiplatelet therapy, or patient-related factors, or any other factor. But for acute stent thrombosis, the most important factor is procedural. So once that happens, it tells you something about the technique of the person who is doing it, and he should correct his technique if this particular problem is happening. Now, having said that, of course, clinical presentation I already discussed, so I won't go into that. But also to say that they can even present with sudden cardiac death and malignant arrhythmias. So if those things are happening also, you would want to look at whether the stent has got thrombosed. And on the other hand, on the other scale, they can be even asymptomatic if the collateral is present, or if, many a times PCI is done out of window period when the artery has already infarcted and the whole territory has already infarcted, and then putting a stent there may not be very beneficial, and even if it gets blocked, then it doesn't cause any symptoms. So that is, I think, one of the reasons why even acute stent thrombosis may not produce symptom if the area supplied by that artery, that myocardium, is already non-viable. Now, the diagnosis is typically made by coronary angiogram, and the main feature is the thrombus originating in the stent segment. However, it can be 5 millimeter proximal or distal to the stented part as well, with typically low TIMI grade flow, 0 or 1, but sometimes the flow can be there also. So this is the basic diagnostic thing. IVUS and OCT can help because, of course, they can confirm the diagnosis, but they can also tell you about some of the mechanisms why that acute thrombosis has happened, whether it is edge dissection, under expansion, or malapposition. And you would notice all these 3 factors are operator dependent or procedure related. So this is, I wanted to say, is the most important thing to remember. Talking a little bit about bioresorbable vascular scaffolds, BVS, we know was associated with increased stent thrombosis at 30 days, about 2%, which was much higher than the usual science rate of 0.3%. And the reason why this thrombosis, early thrombosis was happening was perhaps because of lower strength of the radial strength, suboptimal device expansion, again, as you might see, a procedural factor, and insufficient coronary imaging to see whether any of these procedural details are there, whether it is malapposition, whether it is not properly expanded stent, whether it is edge dissection. So unless you do imaging, you won't pick up those things, and then it is very likely that this complication might happen. But after understanding the whole thing, many trials have shown that the acute stent thrombosis at least is not higher than the regular DES as well. And so basically, if optimal implantation techniques are employed, if intracoronary imaging is done, if carefully selected group is taken without calcium, without a lot of fibrosis, then actually it can be as good as a DES. And I think so this is the main thing about DES. Now coming to procedural stent thrombosis. Uh, Many trials have shown that the rate is less than 1%, 0.7%, but mortality is high at 30 days, 13% approximate mortality. In this particular trial by Brenner et al. But another trial also showed similar things, a rate of about less than 1%, and 5.6% mortality at 48 hours and 10% mortality at 30 days. So relatively high mortality. The risk factors for intraprocedural stent thrombosis were STEMI, increased WBC count, increased thrombus burden, and of course other technical factors like the baseline minimum lumen diameter, total length of implanted stents, bivalvuloidine therapy, which increased this chance, and bailout use of GP2B3A inhibitors. So just to summarize, these were found the risk factors for acute stent thrombosis, and I think I've already discussed them. This Euromax trial was an interesting trial, but because it also looked at acute stent thrombosis, and it found that basically if somebody who has after procedure any complication, then he is very likely to have acute stent thrombosis. RCA PCI was also associated, and use of GP2B3 antagonist, maybe because of a lot of thrombus burden already known, was also related. But on the right side, these are the risk factors for developing acute stent thrombosis. Many of them we have already discussed: prior MI, low ejection fraction, and then intraprocedural problems like uncovered dissections, bifurcation stenting, undersized small stents, severe calcification, multivessel disease, and so on and so forth. Now, this is not a classification for acute stent thrombosis, but a classification Dunga's risk scoring for stent thrombosis anytime in ACS. And you can see that the risk scores have been assigned. 1 to 6 is low risk, 7 to 9 intermediate. So basically you can predict which patients are going to develop these problems. Now coming to the causes of acute stent thrombosis, I already discussed that this is the most important reason, and it could be because of an incomplete stent strut coverage, under expansion, edge dissection, and no usage of 2B3A antagonists. IVUS and OCT can be very important in finding out whether any of these things have happened, so this is highly recommended to prevent. But there could be some lesion-specific factors also, especially in presence of acute coronary syndromes, where on the right, all these things could predispose to developing a stent thrombosis. So if the location and long lesions, bifurcation complex, CTO lesions, calcific lesions, LAD lesions, and SVG lesions. So these are the ones which could predispose. Then of course, patient-related factor, one most important of course, acute coronary syndrome, but even diabetes, CKD, LV dysfunction, renal failure were some of the things. Other than premature discontinuation of therapy, also could be there. Some drugs can be used, and you can see their relation with the acute stent thrombosis. With the newer generation drugs like prasugrel or ticagrelor, there is decrease in rate of stent thrombosis, but interestingly, no decrease in rate in acute stent thrombosis. Because as I already discussed, acute stent thrombosis is because of procedural things and not because of other things. So that is, I think, the main message, that while it did reduce stent thrombosis, but did not affect acute stent thrombosis. And then of course, there were relation to many genetic factors, cytochrome, and CYP2, C19 status, etc. Bivalvuloidine use is associated with increased stent thrombosis. I think that one must remember, and that is why bivalvuloidine is not used too much. Even GP2B3A antagonists can cause increased stent thrombosis because they can cause thrombocytopenia, and that could lead to paradoxical activation of platelet and development of stent thrombosis. So that is another thing. There is this interesting syndrome called Kuhne's syndrome, which is allergic kind of reaction, and if patient has already a stent there, then they can develop stent thrombosis. Then prognosis, I already discussed, so we'll leave it here. Prevention is like you have to look at the procedural factors. Especially be careful with comorbid conditions, complex lesions, and ACS. And there is a group of high risk acute stent thrombosis where you need to, first of all, maybe you can even do monitoring to find out what is the platelet function in those cases, and then you could act accordingly. There are two tests are very important, LT and Verify Now, VASP. These are some of the things that are recent. And again, basically take care of the procedural factors, stent selection, stent technique, under expansion, edge dissection, malapposition, etc. should be avoided. Then some newer agents you could give in those who have high risk, IV cangrelol or GP2B3 antagonists. And of course, if stent design, newer stent designs, the risk have come down dramatically. So finally, to conclude, I would say acute stent thrombosis is a catastrophic perplexing clinical event related to PCI with multiple etiologies. It can be minimized if you can look for high risk patients, even do monitoring in them, and then you could take appropriate steps. But we require more trials. The future is, of course, development of new strategies, newer BRS, which are less thrombogenic, and more efficient anticoagulants and antiplatelets, and better platelet function assessment. Thank you so much for your time.